This webcast and any accompanying materials are copyrighted by the American Association for Respiratory Care. Any public display, sale, copy, or distribution of the video or materials may only be undertaken with the prior written consent of the AARC. Copyright 2015, all rights reserved. My name is Shauna Strickland. I am a respiratory therapist, certified asthma educator, and Associate Executive Director at the AARC. I welcome you to today's presentation, Current Evidence in High-Flow Oxygen in Acute Respiratory Failure.
The leader in humidification systems for respiratory therapy, Fisher & Paykel Healthcare is proud to support the AARC in promoting research that advances clinical practice. The study by Fratt et al., recently published in the New England Journal of Medicine, has significant implications for the use of nasal high flow in the treatment of patients in acute hypoxemic respiratory failure. Now, our innovative new AirVo system mobilizes nasal high flow across the hospital and the home. The AirVo integrates 3 established functions into one purpose-built device designed to reduce length of stay in high acuity areas. Now, directly partnering with all major GPOs and distributors, F&P are also introducing customers across the country to our exciting new technology acquisition program, improving your access to AirVo and MR850 humidification systems. Visit Fisher & Paykel Healthcare at booth 1227 during the AARC Congress.
Thank you, Reagan. Upon completion of this AARC webcast, participants will be able to identify the research question of the study, identify the study design, discuss the main results of the study, and discuss the implications of the study on patient care. I am pleased to welcome Jeff Ward. Jeff is a registered respiratory therapist, certified pulmonary function technologist, and a retired assistant professor of anesthesiology in the College of Medicine at the Mayo Clinic in Rochester, Minnesota. He is currently employed at the Mayo Multidisciplinary Medical Simulation Center. I disclose that I am an employee of the American Association for Respiratory Care. Jeff discloses that he is a clinical consultant with Nonin Medical, Inc. Brand names of products may be mentioned only as examples of technology. Jeff, welcome to the program.
Thank you, Shauna. Greetings from southern Minnesota. We're having a nice Indian summer day. The palm trees are starting to churn. Before I go any further, I'd also like to mention I have some disclosures related to me not taking care of patients on high-flow nasal cannulas in intensive care units. However, I'm pretty familiar with the literature. I'd like to thank Brian Wadier with Core Respiratory Services for assisting me in the production of this webcast. I'd also like to thank Mayo respiratory therapist Steve Hollitz, Rich Hines, and Drs. David Plevak and Richard Aukler for briefing me on the latest happenings in the high-flow nasal cannula world. The key piece of this webcast will be to focus on the article by Fratt. I purposely will not review the technical and physiologic background as part of the high-flow nasal cannula. Bob Joyner did a superb job in his recent webcast, and I would urge you to look at that if you have questions on the technological aspects, as well as pull out your most recent respiratory care, the October issue. The proposed clinical benefits of the high-flow nasal cannula are listed on this slide. As a tool, it primarily improves gas exchange. Oxygenation is its main piece by providing high flows and high FiO2 levels in the face of patients potentially who are very tachypnic and may have gasping respiration. It also provides mild end expiratory pressure. It also helps with ventilation and it is touted as both releasing CO2 from the airways, and in addition to the gas exchange, it also provides some improvements in oxygenation devices that we currently use in terms of comfort and the patient's compliance. There have been some pretty good studies showing that it reduces the sensation of dyspnea. The humidification systems are a little more advanced, so they prevent airway desiccation. So it's a lot less claustrophobic than most masks. It also allows the patients to speak and eat and drink, and also clear secretions. The literature is growing. The first study that I was aware of was a poster produced by Brian Type in 2002. And he showed some of the features that we'll talk about today in an early cadaver study. The things that it does is support hypoxemia a little better than some of the conventional devices, and the ones that have been studied are non-rebreathing reservoir masks, aerosol masks, using large volume nebulizers, Veni masks. And the settings that it's been used in these studies have been the post-operative ICUs, post-extubation, medical ICUs, the emergency department. And the patient etiologies that it has been used for relate to both disorders such as pneumonia, congestive heart failure, exacerbations of COPD and asthma, as well as patients who are recently extubated in surgical ICUs. There have been some limitations. First of all, the selection criteria for patients and the protocols for initiating high-flow cannulas has not always been clear. Sometimes patients put on high-flow cannulas may have had a delay in more aggressive therapy, for example, non-invasive ventilation, i.e. BiPAP, or being intubated and being placed on mechanical ventilators. Some of the settings that it's been used on don't provide adequate staffing, and people who have some experience with the technology, you can't just watch a pulse oximeter. The patients often have to be watched in terms of physical exam cues. Some of the FiO2 data is quite variable. It's very difficult to measure, and oftentimes there are inboard leaks from open mouths, and the CPAP level is not constant as it might be on a mask CPAP system or a BiPAP system, as it is flow dependent and dependent upon the patient. And sometimes there's been practitioner bias where the people have become too exuberant with the either use of the high-flow cannula or are against its use. So the purpose of this webcast is to urge you all to be healthy skeptics. Some people who are watching from Davenport, Iowa, probably know about Otto Rohrwetter, who was the inventor of the commercial bread slicer. And others, maybe who have a German ancestry, may know about Arthur Schopenhauer, who was the quintessential pessimist. But it's probably best if we all keep an idea that the best thing to do is to accept new ideas and technology only after some type of investigation. So part of that investigation is reading journal articles. And I urge all clinicians and students to start making a habit of picking up journal articles, but at least respiratory care, but as well as broaden your scope. And when you do review a journal, you might want to have sort of a systematic approach, and this might be part of either school, journal clubs, as part of a clinical department, or your own personal adventures. So the scheme here is what we'll use. This is from an article that came out in Respiratory Care in 2004 by Dave Plevak and yours truly. So we'll move from there. So it's about a 10-point scale where you kind of go through the journal in a systematic way. So let's start off with a review of the FAARC article. First off, the journal is produced by the New England Journal, is published by the Massachusetts Medical Society. It's peer-reviewed. It's one of the more prestigious medical journals in the world, and it has probably the highest impact factor of internal medicine journals. And why is this important? In terms of the topic, the evidence on high-flow nasal cannulas has had some conflicting results since 2002. There have been a lot of small studies, anecdotal reports, and select patient groups, and this article potentially has the ability to update an international practice. So the title, does it relate to you? Yes, I suspect that treatment of patients with acute hypoxemia is one of the bastions of respiratory care, and hopefully the title of taking care of patients with acute hypoxemia is something you are interested in. However, does it really describe the essence of the study? And the title does not really tell you further about how the high-flow nasal cannula is being compared to conventional therapy, which was a non-rebreathing reservoir mask or non-invasive. And it doesn't really describe the outcomes that are being compared. So the authors, Dr. Fratt and his colleagues, are physicians, MDs and MD PhDs. They report work, or their study gathered data from 23 ICUs in hospitals in both France and Belgium, and they established a FLORALI and REVA network. FLORALI is an acronym for high flow oxygen therapy for the resuscitation of acute lung injury. So the abstract is really like Cliff's notes for the paper, and I'll just read it real quickly. The background is whether non-invasive ventilation should be administered in patients with acute hypoxemic respiratory failure is debated. Therapy with high flow oxygen through a nasal cannula may offer an alternative in patients with hypoxemia. And the methods report about a multi-center open-label trial in which the patients were randomly assigned without hypercapnia who had hypoxemic respiratory failure and a PF ratio of less than 300. They were randomized to high-flow oxygen therapy, non-rebreather mask, or non-invasive positive pressure ventilation, or BiPAP. The primary outcome was the proportion of patients intubated at day 28. Secondary outcomes included all-cause mortality and the intensive care unit and at 90 days, and the number of ventilator-free days at day 28. So that's the abstract. And then the results are shown here in the abstract form. 310 patients were included in the study. The intubation rate was 38% in the high flow group, 47% in the non-rebreathing reservoir bag mask, and 50% in the non-invasive group. The p-value was 0.18 for all comparisons. We'll talk more about the p-value as we move along. The ventilator-free days is shown there. They talk about the hazard ratio for death at 90 days. And in the conclusions, in the patients with non-hypercapnic acute hypoxemic respiratory failure, treatment with high-flow oxygen, standard oxygen, or non-invasive ventilation did not result in significantly different intubation rates. There was a significant difference in favor of high-flow oxygen and 90-day mortality, and they talk about their funding. Well, the next idea is to review the literature and in the background or the introduction of the paper. And they talked about, the authors talk about the controversy in non-invasive ventilation and preventing intubation in de novo or non-hypercapnic, non-cardiac, or without underlying cause lung disease, hypoxemia. They talked a little bit about how the patient selection often has overestimated the benefits of non-invasive ventilation because they include hypercapnic patients, or they include patients with pulmonary edema. And the non-invasive failure rate is relatively high, and the intubation rate's relatively high, and the patients have a relatively high mortality. And to date, there is no literature that conclusively supports non-invasive ventilation for acute hypercapnic respiratory failure. So they said that what they would like to do is to improve the outcomes if the non-invasive avoids intubation and to determine whether worse outcomes occur if failed non-invasive ventilation delays intubation. So in terms of the background, a little sidebar, where do they get the data that says the 50% failure rate for non-invasive? And the second author of the FAARC study produced a paper in 2013 in Critical Care. And then the statement in terms of high mortality is also shown there, and that paper came from Mass General. On the third paragraph, they finally get around to talking about high flow nasal cannulas, and they describe and give references for its ability to produce the effects that we all know and love so well, and of high flows and adjusting FiO2 and flow independently, reducing potentially dead space and work of breathing, and improved comfort. And the citations that they use there are shown of note are of several publications that were published in Respiratory Care. I'll just quickly mention the FAARC study, which was published in 2015 in February, and this was a pilot study that looked at using high flow nasal cannula with non-invasive ventilation in combination therapy. And they looked at a small group of patients, about 28, and they found that they could use the high flow nasal cannula sequentially in between non-invasive ventilator applications, and they were fairly pleased with that and said that it seemed to avoid impairment of oxygenation in between non-invasive therapies. So back to the background. Finally, the researchers described the research question. In quotes, in patients admitted to the ICU with acute hypoxemic respiratory failure, they wanted to determine whether the high flow nasal cannula or non-invasive ventilation as compared to standard oxygen therapy alone could reduce the rate of endotracheal intubation and improve outcomes. So in the statisticians' world, the null hypothesis is the sacred approach. And the null hypothesis is sort of reversing this, and they're saying the null hypothesis for this research would be there would be no difference in intubation rate or outcomes between the high flow cannula, non-invasive ventilation versus the standard oxygen therapy administered by non-rebreathing reservoir bag. The study type was prospective. It looks at outcomes during a study period. It was multi-center. It looked at multiple medical facilities. It was open label. With devices such as this, it's impossible to blind observers and have a placebo versus a control system. And it was a randomized control trial. Participants were assigned to a study group or arm with treatment conditions at random, and the procedures were controlled to ensure that all the study groups in each arm were treated the same, except for the factor that was unique to that group. So there have been a couple of similar studies, and I'll show them here in case others are interested. And one, of course, was published in Respiratory Care. The methods section, this is where you look to see what's going on behind the curtain, under the hood. It would appear that there was adequate informed consent. It would appear that there was a consideration regarding safety. And one of the remarkable events were that the protocols were all carefully described. If you go to the New England Journal's website and look at the full text article, you can go back and find the protocols listed in the supplemental materials. In addition, there was a coordinating center for these 23 hospitals, an investigator at each area, in each hospital, and everyone was made unaware of the study group outcomes until the data was revealed. Outside funding is a concern. In this case, all the consumables were supplied by the individual hospitals. And Fisher and Pickel did supply oxygen-air blenders during the study. In terms of the method section, the patient's criteria for inclusion were the patients were over 18 years, had a high respiratory rate, and a PF ratio of less than 300 on 10 liters of oxygen administered by non-reservoir mask. A note here is that FiO2, to determine the PF ratio, was made by a measuring technique inside the mask. PCO2s had to be less than or equal to 45. The patients were excluded from this study were those with chronic lung disorders such as asthma, COPD, patients with cardiogenic pulmonary edema, severe neutropenia, unstable hemodynamics or on vasopressors, patients who had a reduced level of consciousness, unable to maintain likely their airway with a Glasgow coma scale of less than 12, patients who had a clinical suspicion of needing to be urgently intubated, those who had a DNR order or DNI order, or the patients obviously who did not want to participate. The patients were randomized in permuted blocks. This is a statistical technique where there's a 1-to-1-to-1 ratio. In this case, the patients had 6 patients were administered natural breathing bags, high frequency nasal cannula, non-invasive ventilation in blocks of 6. The standard interventions are shown there. One would be the non-oral breathing reservoir mask at 10 liters or more to maintain a PO2 of 92%. The high flow nasal cannula used the large bore OptiFlow cannula with a Fisher Pickel MR850 humidification system, and the blender was set at 50 liters a minute and adjusted to maintain SPO2s of 92%. And it was applied for a minimum duration of 2 calendar days. Non-invasive ventilation was a little more difficult to understand, at least for my part. There was a Fisher Pickel face mask. There was a typical ICU ventilator that was put in the non-invasive BiPAP mode with pressure support levels set to deliver tidal volumes of 7 to 10 mils per kilo predicted body weight. Initial CPAPs were set at 2 to 10. The FiO2s or peaks were adjusted to maintain saturations of 92%. This was applied at 8 hours per day for at least 2 calendar days, then the sessions for at least 1 hour a day. And in between these sessions, the high flow nasal cannula was the delivery device. So the study outcomes are shown here. The primary outcome was the proportion of patients who needed to be intubated in each of the study arms within a 28-day period. The secondary outcomes were ICU mortality at 90 days, the number of ventilator-free days from day 1 to 28 days, and complications due to sepsis, nosocomial pneumonia, cardiac arrhythmias, cardiac arrest. They also made an assessment of dyspnea and comfort. I'm going to quickly show the criteria for intubation. This is in the supplemental materials. I think that the study was very appropriate to carefully identify this for all the special hospitals or the separate hospitals involved. And when using this device, I think it's very important that everyone know when to stop the high flow nasal cannula or stop the non-invasive ventilation or stop the non-reservoir bag mask for a patient who is deteriorating and needs intubation. The statistical analysis, they did a power analysis, and the power analysis was based on the literature that showed that typically in the non-invasive ventilator group, an intubation rate of 60% was a sort of a historical control. And they felt a good clinical difference of 20% would compare the non-reservoir bag mask and the high flow nasal cannula. So this established the power analysis, which they calculation determined would require about 300 patients for this discrimination. They used a 2-sided alpha test that allowed an equal shot in both groups for being intubated. And they used Kaplan-Meier curves and log rank test, the Mantel-Cox test to compare the survival curve distribution versus the controls. And they used odd ratios for that calculation. So the variables associated with intubation used a multivariate logistic regression analysis. They used the Cox proportional hazard regression analysis and a two-tailed p-test with a p-value of 0.05 considered statistically significant, and these were set by the researchers. The post hoc analysis of patients with PaO2s and PF ratios of less than 200 was also done as part of a classification for ARDS. For those of you who recall the null hypothesis reverses things, saying there's no connection of the observations being significant. In a legal metaphor, the patient would not be guilty. So the p-value is a probability of obtaining an equal result to or more extreme than observed. And if it's small, it suggests that the observation is inconsistent with the null hypothesis and it can be rejected. In other words, it's a good probability of an equal result, and that is the patient is guilty, not innocent. So in this case, rejecting the null hypothesis would mean that there is no connection with the equal result. So a p-value is shown here in a single tail test. So there's a 5% chance of inappropriate acceptance of the null hypothesis. This shows the breakdown of selecting the patients. Initially, the 19,528 patients were admitted to the ICU. A number of those were excluded based on what we had just mentioned as the exclusion criteria. They got down to 2,500 patients admitted to the 23 ICUs with acute hypoxemic respiratory failure. Of those, 500 met the inclusion criteria. 212 were excluded based on logistics, or they either declined, leaving us with a group of 313 patients for randomization and treatment, and that took place within 1 hour. So there you see the 94 for the non-rebreather, 106 in the high flow cannulas, and 110 for non-invasive ventilation. This is just a bigger graphic of showing the patient randomization. I'll just make a point here in that there's a significant selection for this study. So the notable characteristics of 64% of those had community-acquired pneumonia. 79% had bilateral infiltrates. The respiratory rates were all similar, in excess of 30. Issues of note, the patients were randomized or at least observed for simplified acute physiology score, SAPS-2, and they were not sort of analyzed for Apache 2. That's a consideration that some might suggest could be a better predictor of mortality. Another fact that is notable is that it would appear that there are sicker patients in the non-invasive ventilator group, 7 of which had extrapulmonary sepsis versus 4 and 5 in the other 2 groups, and 10 with pneumonia related to immunosuppression versus 6 and 4 in the other 2 groups. And this is just another slide showing the patient characteristics. The oxygenation goal for all patients were to maintain saturations of 92%. The high flow nasal cannula was set at 48 liters per minute, producing an FiO2 of 0.82. And that FiO2 was determined not by analysis, hypopharyngeal analysis, but by looking at the blender. The non-invasive, the non-rebreather bags were at 13.5 liters per minute on the average, plus or minus 5. And as we mentioned, the non-invasive ventilators were set to deliver CPAP-PEEP at 5, plus or minus 1. Pressure supports were set at 8, at plus or minus 3, and the FiO2, which was able to be measured, was 0.67, and it varied plus or minus 0.24. So now moving to the results. The primary outcome at day 28 showed the high flow nasal cannula patients had a 38% intubation rate, the non-reservoir bag 47%, and the non-invasive ventilator patients at 50% with a p-value of 0.18. So this showed that the patients, no hypothesis was accepted. There was no difference in this primary outcome between the three randomized groups. And the other point that I might mention is the steepness of the cumulative index of intubation. Notice how almost all the patients were intubated before day 4, and the majority intubated within the first day or so of the trial. So the subgroup analysis for the patients with the PF ratio less than 200 actually showed that the patients did a little better. And I am not sure how to really interpret this data, but there was significance in this group. And again, the point that can be made is that there was a high incidence of need for intubation in the first few hours and days of the trial. Second outcomes, the intervals between enrollment and reasons for intubation did not really differ significantly. The ventilator-free days were a little bit higher in the high-flow nasal cannula group, 24 versus 22 in the non-reservoir bag mask, and 19 in the non-invasive ventilator group. So it's a p-value of 0.02. The ventilator-free days were a different calculation. 1 point was given for each calendar day during the measurement period. That is, from the first day of randomization to day 28, patients were both alive and free of invasive ventilator. So a 0 value was given for patients who died before extubation and day 28. And a patient extubated on day 2 of the study, remaining alive and free of the ventilator for the remainder of the 28 days, would receive a score of 26. Or someone that received mechanical ventilation early on and on day 2 and then died would receive a score of 0. The other results and the data that is most interesting, at least for some, is the death in the ICU. And hazard ratio for death is shown here. So non-reservoir bag versus the high flow nasal cannula shows a 2.1 hazard. That if there was 1.0, that means there would be no difference. So the reservoir bag was a little more of a risk than the high flow nasal cannula. In the high flow nasal cannula versus the non-invasive, 2.5. So the non-reservoir bag, 2.1. This shows the graphic of the outcome, and the significance of this is the area under each curve. This shows that the high flow nasal cannula group did a little bit better than either the standard oxygen or the non-invasive ventilation. This is again a graphic showing that. The results, the secondary results relating to outcome at 1 hour after inclusion in the study shows really no significant differences between the high flow, standard non-rebreather bag, and the non-invasive group. The rate of complications did not vary significantly among the groups. The serious events though, are probably worth mentioning. There were 18 cardiopulmonary arrests of the 300 patients, 3 prior to intubation, and then 2 patients died during intubation. So in terms of discussion, the authors agree that they would accept the null hypothesis, no difference in reduction of intubation. They assumed a 60% intubation rate based on historical random controlled trials, and in this study there was a 47% in the non-reservoir bag, 38% in the high flow, and 50% in the non-invasive group. And again, we talked about the 60% coming from historical trials. Those citations that were used are shown here. The discussion related to mortality, there was some concern that the patients put in the high flow or the non-reservoir bag mask groups would have a delay in intubation. The researchers were very clear in their intubation criteria. This was really not the case, and it did not apparently occur. The possible reasons for the reduction in the high flow nasocannula mortality group were noted by the authors as a cumulative effect of less intubation, particularly in the severe PF ratio group. The high flow nasocannula group were later intubated versus the other groups. And then they also mentioned the potential for a reduction in ventilator-induced lung injury that might have occurred in the non-invasive group if the tidal volumes were greater than a protective lung strategy. The limitations that the authors described were low power to detect significance between the group differences in intubation. And the conclusion is that the treatment with the high flow nasocannula in patients with acute hypoxemic respiratory failure showed no reduction in intubation versus the standard oxygen therapy or non-invasive ventilation. Treatment with a high flow nasocannula improved survival rate in patients with acute hypoxemic respiratory failure. So concerns were raised via letters to the editors that occurred subsequent to the article, and I'll just identify those real quickly. One group wrote in saying that large numbers of exclusions allowed an unbalanced distribution of variables which may have affected mortality, and that only 313 patients were selected out of the 2,500. And there was an uneven prevalence of septic shock. And Frott and his colleagues replied that there was a focus on patients without organ failure. Community-acquired pneumonia was the main cause, and that they felt the patients did have a similar immune status, and there was a trend toward septic shock in the non-invasive ventilator group. Another group talked about the small number of mortality events, and there was a concern in that there was perhaps underpower for this sample size. The authors replied that intubation rate was significantly different in the high flow group, which was felt to be the main drive for mortality. The results were similar to other studies which they referred to. Another concern related to the editor's column was the concern for effect of repeated initiations of non-invasive ventilation may have caused decreased cardiac output, and that refractory shock may have been part of death in that area. And they asked that lactate and vital signs be part of the analysis. The authors felt there was really no difference in blood pressure or heart rate after initiation of non-invasive ventilation, so this was a moot point. Another concern was that the duration of non-invasive ventilation was suboptimal. They disagreed with the author's attribution of success in its ability to generate end expiratory pressure, as its mean pressures are relatively low. The authors felt that 8 hours was all right, and that half of the patients on non-invasive ventilation required intubation, during the duration of non-ventilation was really underestimated. And they noted that the non-invasive ventilation patients did receive high-flow nasal cannula in between sessions. They agreed that the CPAP level was low, but countered that humidification and high flow was an improvement in reduction in discomfort. So, if we're getting close to ending here, I will display my 1960s R. Crum Mr. Natural figure, where we'll see if we can determine what this all means. I'd like to note that the FAARC research group made a significant contribution in evaluating the high-flow cannula versus conventional oxygen therapy in acute hypoxemic respiratory failure. They need to be saluted in terms of the volume of patients that they accrued, and they had careful patient selection. Their protocols were well in place, and it would appear that they were very diligent in monitoring in the ICU setting. And initially, it would appear, based on the pilot study by FAARC, that they were really concerned about patient comfort and the failure of non-invasive ventilation based on patients' refusal or having a difficult time of complying with the mask therapy. And this research also, I believe, underscored the use of high-flow cannula as an oxygen therapy delivery device and its value in combination with non-invasive ventilation. And again, we refer to that pilot study that was produced in or published in Respiratory Care in February of this year. Some concerns with regard to the design. Two oxygen delivery devices were compared to a ventilating device. The use of non-invasive or BiPAP was the third limb, I guess, and it might have been cleaner if non-reservoir bag high-flow nasal cannula were compared to CPAP. Application of the non-invasive ventilator to the various groups, 50% had the non-invasive applied for less than 8 hours, and 5 of the high-flow nasal cannulas and 7 of the non-reservoir bag mask patients had the non-invasive ventilator applied as rescue therapy. So that it would appear that there was a little cross-pollination between the groups. The accuracy of the oxygen delivery as measured in the non-reservoir bag and high-flow nasal cannulas may be suspicious in terms of the PF ratios because of the potential for inboard leaks. Also, I was a little surprised to see that the data on dyspnea relief and comfort was not as revealing as other studies have shown. And the other piece was the perspective, in that I hope that that the readers did not determine that there was a focus on 3 devices to support oxygenation for these hypoxemic patients versus more of a focus on comprehensive therapy. These are support devices. In terms of mortality data, this is a post hoc analysis. Whether it's valid in terms of power for the mortality is a concern. And the other piece is, does this make sense? Is there a physiologic basis for the improved mortality in the high-flow cannula? Might it have been done to selected patients? Patient selection could have been to the sicker patients in the non-ventilator group. Could it have been done to the larger tidal volumes in that group? And we're left to wonder whether high-flow nasal cannula is really beneficial, or is it non-invasive ventilation deleterious? Another piece is the decisions to allow patients to die. Was it influenced by patient directive or family versus failure of the life support systems? So And sort of wrapping this up, the non-invasive ventilation has a well-established role as first-line support in COPD and cardiogenic pulmonary edema. It is still not clear for ARDS. The evidence remains mixed as it's compared to high-flow nasal cannula and non-invasive as a first line in de novo acute hypoxemic respiratory failure. The non-invasive ventilation failure rate is still relatively high. There's an extended treatment and poor tolerance of non-invasive ventilation, which is associated with intubation. And early intubation is associated with survival. So there is potential advantage for selected patients, potentially on acute and chronic respiratory failure, mild acute respiratory distress, post-extubation, failure post-lung transplantation, and as we've seen, in combination with non-invasive ventilation. So in summary, I think that there is a growing efficacy for the adult high-flow cannula as a very effective device to improve FiO2, higher flows, and independent control of FiO2 and flow. It does have mild end expiratory pressure benefit. Controlling that is a little dicey. So the perspective for its application, I think, requires not just grabbing another gadget out of our closet, our inventory of oxygen therapy tools, but it requires that we step back and integrate high-flow cannulas as we look at patients' gas exchange needs, their patient muscular efforts, their cardiovascular status, age, as well as their underlying lung problem. I think that it behooves us to look at the patient selection extremely carefully. Dyspnea, tachypnea, and thoraco-abdominal dysynchrony are hallmarks of a patient who's failing. And if a patient is on a low-flow cannula, non-reservoir bag, or a diluter aerosol system with FiO2 is less than 0.4, the high-flow cannula certainly should be considered. Patients who can't comply with mask-type therapy certainly should be considered for the improved comfort and tolerance with a high-flow cannula. Patients are potentially well-suited for the high-flow cannula as an alternative for do not ventilate for DNI patients, or non-invasive ventilator patients for DNI in comfort care to improve comfort and reduce dyspnea and to keep them out of ICUs. So the future for the high-flow cannula, I think, is for all of those watching, is to make sure that you have some type of protocols for application as well as discontinuance. There needs to be some education and training of respiratory therapists with emphasis on bedside assessment skills. Also, in addition to the nursing staff and physician staff who are taking care of these patients, need to be brought into the loop. And then some type of national clinical practice guideline to include the high-flow cannula, I think, is appropriate. The last guidelines for the CPGs in respiratory care, I think, are 2002. So for further reading, for review articles, there's a great one in CHEST that's 2015. There's an older one in 2013 in respiratory care. The October issue of Respiratory Care should be prime reading in addition to the editorial. And at this point, I'd like to open it up for discussion. And Shauna, if you'd like to field questions, I'm ready to go.
Thank you, Jeff. That was really, really great. The chat room has been really active while you've been talking, and one of the bigger discussions has been around the level of flow that was used in the study. The researchers used a flow of 50 liters per minute, and one of the comments in the chat room was that here in the U.S. we tend to use around 30 or 40 liters a minute. Now I know that in the October 2015 issue of Respiratory Care, FAARC et al. Has an article discussing the potential for high-flow nasal cannula flows up to 100 liters per minute. Were the researchers concerned about comfort levels, or did they mention anything about persons feeling uncomfortable with the high flow systems with a flow of 50 liters per minute?
I looked carefully at the supplemental materials as well as the paper itself, and they really didn't address the titration of flow. I think that's where the art comes into play to some extent, in that if the patient's respiratory rate is really high and they're struggling to breathe, I think that the bedside therapist tends to crank up the flow. And to what level, I don't think that there is a formula. I think that if you titrate, hopefully, to patient comfort, I don't know if going to levels of let's say 90 to 100 are really advocated. It would seem that there's going to be a lot of potential CPAP development at that level, which for some patients may be an advantage, and others, potentially some with obstructive lung disease, this could be a concern. So back to the original question, the authors did not address setting the flow to a certain specific level in the FAARC study.
Thank you very much. And the FAARC study, if anyone's interested in following up on this, again, in the October issue of Respiratory Care, the FAARC study, it was a bench study, so it certainly wasn't trialing these flows on actual patients, but it was coming up with a good statement of whether or not flows over 60 liters per minute are helpful, whether it would create the right therapeutic result or not. One of the other questions that was bantied about in the chat room was about the diagnoses of the studied participants versus the patient population as a whole, and what implications that might have on our ability to translate the results into practice.
And that's a really important question. As you saw, the FAARC group were extremely diligent, and I think that is key. Of the 2,500 patients that had acute hypoxemic respiratory failure, only 1 in 8 were included in the study, and that there were a lot of patients who had problems in terms of inability to maintain an airway, had to be urgently intubated. That was an important. 476 patients had to be urgently intubated. So if you distill that down into daily practice, I would think that the high flow nasal cannula is not something that you would have at every bedside, like a chicken in every pot. I think that it is a tool that needs to be available for a selected number of patients. And the thing that really is important is to focus on the medical problem and integrating all the patient issues, and not focusing necessarily on one specific tool. So, maybe if you think of it as maybe 1 out of every 8 patients who comes in to an ICU with acute hypoxemic respiratory failure is really well suited to a high flow nasal cannula. I mean, they're sort of the poster child.
Thank you, Jeff. This has been an excellent session, and I'm so glad that everyone was able to join us. If you haven't done so, I would encourage everyone who is listening with us to check out the actual study on the New England Journal of Medicine website. And Jeff, again, I thank you for joining us today.
You're welcome. I really appreciate the opportunity, and I think it's really important that respiratory therapists read this because it's become a big news, and there are going to be a lot of physicians buttonholing you and asking you what you think about the study and how it should be translated at your hospital.
For those of you watching this as a live presentation, please stay with us during the next brief pause for instructions on how to obtain your CRCE contact hour. If you're watching this program as an archive, this concludes our presentation.